Let's see. Okay.
Um,
Awesome. Oh, go ahead. You can go for it if you want.
okay, cool. I was just gonna say hi, everyone. I'm Sydney. I'm the addiction resource professional. So many people are on here. This is like so different from many other office hours. I'm so glad you came. Jennifer and I talked about doing, you know, current research things, but there was so much chatter on the discussion board about, running groups, nutrition groups in for this population. And I don't know, I just kind of felt like before we dig into a research article, oh, that's good to know. Timing is better for East Coast people.
That's been an issue for what, like the 4 years I've been in this position, getting these scheduled for
Okay.
the most amount of people coming. Yeah.
That's good to know.
Awesome.
So yeah, I just wanted to open it up and first see if anyone had anything top of mind that they wanted to talk about. This is kind of like office hours. It's an open space, and if no one has any topic or thing that they were hoping to discuss, then we can talk about this one article I have.
Yeah, real quick before y'all get started, it is recording. You should have gotten a little consent already from that. Y'all feel free to come on screen and talk, but if you want to be anonymous, shoot me a private message and I'll just ask the question, put it out there for you. Yeah, I think that's all I've got. People are still coming in. Y'all are awesome. I recognize some of the names from the posts on the discussion board. So yeah, y'all take it away.
So I can start us off. Can everyone hear me?
Yeah.
Okay, awesome. Hi, Sydney.
Hi.
So I wanted to ask about your thoughts on GLP-1s meds as anti-craving for substances.
Stephanie, it's almost like you were my little plan because that was the research article that I pulled for today.
Okay, little bug in your ear.
I know we got that telepathy. Okay, so I'm gonna make a list of topics and I'll put GLPs as one. Does anyone have anything else that they're coming in with?
I missed part of that conversation because my earbuds were going crazy, but I'm assuming that was about the GLP-1 and addiction angle and like fascinated by it. Like I would second that request. I haven't had
Yeah.
a chance to deep dive the research yet.
Yes, that was the question.
Yeah.
About cravings.
Yeah.
Yes, yes. And I guess kind of to that, I mean, of course, we could dig real deep into there, but just tying into eating disorders as well, or a history of eating disorders, but more so like GLP-1s being used as medical assisted therapy, kind of like naltrexone and Vivitrol have traditionally been used. I mean, not always, but and now seeing a lot of GLP-1s for like in combination or even standalone
Mm.
with MAT.
Are you seeing that right now with your patients? Like, are you seeing it being used already?
Yeah, so we are actually one of our physicians at Karen Treatment Centers got grant money to trial the medication with our patients. So it's trialing it and doing some research at the same time. When I say we, I mean Karen and this physician. I'm not actively involved in the research, but we are. I push to get referrals for the patients because many of them have a history of an eating disorder, even some active when they come to us. And so it's just bringing up a lot of things for us on the nutrition end.
Are you open to sharing what you're seeing?
Of
On
course. Um, yeah. So again, I think when our medical department was kind of looking at this to pilot it as another tool in the toolbox, everyone's really excited about it. And of course, myself and our other two dietitians here and two dietitians in Florida as well. Like, hey, we can. This is a great again, tool. It shouldn't be a band-aid. However, we need to also have our eyes on these patients from a nutritional standpoint, history of an eating disorder or not, but just with the research we do know. And again, it's still so early with the weight loss, the rate at which the weight loss potentially happens with muscle wasting. So I really reached out to medical to get, more of a holistic approach with these patients. So we're getting referred to them. The dietitians are our recreation staff because we do have a fitness center here. They're making sure these patients, they're kind of flagged on their end. So if they're coming to the fitness center and doing, cardio for the hour, they're trying to intervene, talk to them about the importance of weight training and a more balanced program. And we're making sure if they have reduced appetite, they're still going to meals, they're prioritizing protein, and really trying to essentially force themselves to eat. If seen so far is like we're using a therapeutic dose, they're calling it, which is like, and primarily Ozempic, which is like a 0.25 to zero point 0.5 milligram dose, I believe. And so, because it's at a therapeutic dose and a lower dose, we're not seeing much impact on appetite, luckily. It's more so just to quiet the quote unquote phrase we love, food noise, and cravings for substances and really any kind of substance. Like we started with alcohol and opioids, but we've seen now patients being placed on it really for any kind of substance craving. So I
Wow.
think that's in a nutshell, um, kind of where we are to date with it. But I kind of had to fight my way in there to say like, hey, we need to be in front of this and we need to be a part of this. This is great if we want to use, but like it needs to be a more holistic approach. So
Oh my God, I'm so glad that you kind of fought your way in and just like how ridiculous that. Did you say at the top that the nutrition department is not part of the research study?
no, we are not at this time.
Yeah, it's so unfortunate. Okay, well, that's a great topic. And I'd also just be curious to hear kind of like clinically what you're seeing with that, if anything yet. But so we could look at that and then also look at this one research article. So if you're just popping in, we have one topic, which was the research article that I thought of, and Stephanie and I are on the same page. She brought up GLP-1s and how it's being used potentially with cravings for substances. Does anybody else have anything they were hoping to go over today?
Okay, there's one in the chat. She had mentioned like topics. She's seen referrals for patients that have been having weight gain since being admitted, which is super common. Focus on general health and nutrition, but I don't know. And Lisa, you can pop in there if you're looking at like specific like nutrient like interactions with different substances, or maybe yeah, just let us know if there's this particular thing, or if you're looking at like topics to have in group sessions or anything like that, just so we make sure that we answer that question as fully as you're looking for. And then, yeah, if anybody else has anything, topics for group. There you go.
Cool. Okay, so we have two good ones, it looks like. And if there's any other questions or topics anyone wanted to talk about, you can drop it in the chat and we'll see if we get there. But so maybe I'll start by just sharing my screen and I'll drop the link for this paper in the chat.
Are
So
you
you,
set as the host, co-host? Let me see.
oh, I can share my screen.
It'll let you. Okay.
Yeah. Um, okay, so can everyone see my screen?
Mhm.
Okay. So, recent paper published in October looking at GLP-1 therapeutics and their role in alcohol and substance use disorder. So, I guess maybe just raise your digital hand to start, but I'm wondering, does anybody currently have, clearly Stephanie does, but any patients with substance use disorders that are on a GLP-1 specifically for substance use?
It's cool. I have somebody that's on it and has noticed cravings are a lot lower, but that's not why he's on it for diabetes.
Mm.
But that was one of the first things he said to me was, and that he was heroin use. He said the cravings have just gone away. So
Was he actively using before?
he was not. So he went into the hospital during COVID lockdown with the overdose and found out he had diabetes and COVID all at once and just stopped, didn't go through a program or anything like that. So from the sounds of it, he was white knuckling it. I've only been seeing him for about maybe 6 months at the most. But he said that was one of the first thing he noticed when he got on there is he doesn't have any thoughts about using any cravings, anything like that. So he's a little bit further along in the process, maybe, but
Yeah, interesting. I'll share. I have one client who does not have an alcohol use disorder, but is able to drink socially. And she noticed after being on Manjaro that pretty quickly, that she didn't even want to have a glass of wine socially anymore, that it just like didn't appeal to her. So, we're hearing anecdotal stories, and it kind of alludes to that in this paper, that we're hearing of people say that their cravings for alcohol um, and nicotine is decreasing. But in terms of what the research is actually saying, um, just to go down a little bit, and I think even seeing this subheading, I also share, I work at the intersection of substance use and eating disorders. So it's interesting, right, that they're layering in also obesity with this subject. In my mind, I felt a little disheartened that they were including that in this paper, because if we're going to talk about substance use, let's talk about substance use. Why are we needing to layer in the obesity part as well? Um, and also from this paper, there was no discussion of eating disorder. So to Stephanie's point, I think when what I'm seeing in general, mainly most of my clients have eating disorders. I have about 10 clients that are on some version of a GLP-1, and they all have some form of disordered eating. And, a lot of them have gone on this medication against my advice, but are being monitored. And I think it's an interesting, if we think about GLP-1 use, especially in the population of substance use disorders, knowing that the crossover between substance use and eating disorders is so high. Um, to think, what's on the horizon if somebody goes on this medication for cravings for substances, who's at a higher risk of developing potentially an eating disorder or disordered eating. So it's a great question. And just going down a bit, I'm assuming that we all know at this point how GLPs work, and the mechanism to how they're having an impact on people with substance use disorders is still not fully understood from what I've read. But we know that it can affect kind of the dopamine reward pathway in the brain. And a lot of the research that's been done so far showing decrease specifically with alcohol has been done in rodents. And if we go down here, so they've seen um, that in rodents using a GLP-1 receptor agonist, some of these specifics, which are just different, they have different, what's the word? Like doses, like long acting, reduce alcohol intake, which is interesting. And then we go down and see here, there have also been anecdotal human reports of reduced alcohol use posted on social media. Again, just interesting how this is coming in to be researched. Um, we have here only two randomized control trials. have been published so far. The earlier control trials showed no significant effect of, again, a GLP-1 on alcohol consumption in people with alcohol use disorder. Um, and then in another study, it showed that number of drinks consumed in a given day was decreased. Um, Another interesting semaglutide reduced the number of cigarettes smoked per day. Um, Mixed research in terms of opioid addiction. So I'd just be so curious, Stephanie, how the study is being set up since it's being used, it seems like across substances.
Mhm.
Um,
I've wondered too on these if desire to stop drinking or stop whatever the addiction plays a role in whether or not it helps, you know?
like
Um,
motivation in general.
yeah.
Yeah.
I've even seen outside of substances, so like anecdotally, gambling and shopping addiction being
Mhm.
modified too. So,
Yeah, and I don't even know exactly like what data they're collecting for our patients here. I know it's they're following the patients after they leave, right? Because most of patients stay with us for, 28 to 30 days. Some do step down to our PHP level of care. This grant that we have gives patients the GLP-1s at a reduced cost for 6 months. So I'm not sure exactly like the data that they're collecting while they're here, how they're collecting it when they leave. And then after, those 6 months, like what happens? I mean, then if they have no insurance coverage, that's kind of my concern. Like, and they can't maintain the medication. Like, we just kind of like they're 6 months out, maybe hopefully connected somehow if they're not in sober living, like an individual therapist. But then their cravings are through the roof. They start to gain weight, and like, what does that look like for someone?
right.
So yeah, I'm not exactly sure, and I can get more details, like exactly what the data they're collecting, but I'm not even really sure to be honest with you, Sydney.
It's fascinating, especially, okay, so they're getting coverage for 6 months of the
Mhm.
medication. And what we know now about people being on this medication for weight loss specifically is that they're seeing that after about 1 year, people go off the medication, whether it's cost, lack of coverage, or a plateau in weight. So super interesting to think about that from a substance use side. I mean, in the weight category, what I hear from clients is, oh my God, do I have to be on this forever? If I go off of it, am I going to gain all the weight back? But when we think about how body image distress can come up in this population, that, yeah, totally. Like cravings for substances going back to skyrocketing after stopping the medication, but then also those body changes. And what does that mean for relapse potential?
Right.
Um,
Right. Yeah, it's scary. I'm glad we're able to talk them through the process a little bit, or like what's to come, or like what it could potentially look like. And it's just so early. Like, how do we even know? Like how to educate them. That's like our struggle. We're telling them being transparent as possible, but like because they're so new for this, we don't really know. Um, so I just don't want to set them like feel like we're setting them up for failure in any kind of way.
Yeah, what interests me is I wonder, and anybody else chime in, but what I'm seeing for clients that are on these medications is I'm thinking of one client who has been on two different, she was on, I think she started on Ozempic, now she's on Zepbound. She's hit the ceiling for her dose. Really barely, maybe had 10 pounds of weight loss. And she's someone that it was like she had PCOS and a lot of other stuff going on. And so just thinking about does the same thing apply with substances, where if someone's not seeing um, cravings decrease at a low dose and then they have to increase and then increase again, or just the plateau, I'd be so curious to how that works.
I feel like I've been hearing more on the weight management side of the discussion that like you don't there's not an exit plan because there's not they're not supposed to exit, like they're supposed to stay
Mhm.
on it. I've been hearing a lot more. A webinar very recently actually was very clear on like they stay on it, which is something else to think about.
I heard that too, and like medication fatigue, like with that, like knowing that they have to stay on it and getting sick of taking it.
Right.
Mm-hmm.
I've tend to take it with my clients is that so now you have this reduction in food noise. Maybe you have a little bit more space to be like learn mindfulness and like learn other things. But if you don't learn that and then you go off the medication, you know what I mean? Like I think there's just I don't know. I think there's a lot we don't know about the medications as much as we would
Mhm.
like to know about it, you know?
Totally. And pregnancy, I'm thinking, I mean, I don't know the updated guidelines, but like 2 years ago when I had someone on it, they had to go off of it once they got pregnant. And so I'm just, again, thinking about it specifically for clients with substance use disorders. I mean, what a nightmare that would be.
Mhm.
Um, so if we go down a little bit more, again, I feel like it's always the same. Future research is needed. But another part that is interesting, I don't know if anyone saw the post. I think it was on the Washington Post or another one about it was an anecdotal story that someone shared how once they came off of their GLP, they were able to like see life in color again and food had flavor and their sex drive was back. And so this idea of like what pleasure is being dulled via GLP-1. It's a conversation I have with clients all the time. This like I hate the thing now of food noise. It's like we don't have a standard definition for that. Is it just that you're hungry? Maybe there is preoccupation around food, but this idea that, there also have been reports of depression in those who take GLP-1s, raising concerns about increase in risk of self-harm and suicidality. So it's a really vulnerable group to be exploring this with. And then I'll stop talking when I hear from everyone. I think my biggest thing with the GLP-1s, and it sounds like you guys are doing this beautifully, Stephanie, is like informed consent. You gotta like focus on nutrition. We need to maintain muscle mass. I tell clients you're not going to have a lobotomy just because you take this medication. And if you're somebody that doesn't like fruits or vegetables and you just think like, oh, I'm going to take the medication and love eating, healthfully, that's not what I'm seeing. I'm seeing clients just get away with like some candy during the day. And some clients being like, wait, why don't I want kale? It's like, well, this doesn't change you as a person. And the biggest worry I have is for similar to eating disorders, but for other clinicians like therapists or psychiatrists don't really specialize in substance use, but say they see it and then they kind of who doesn't love a quick fix, and especially in this population. I mean, I've lived experience as a sober person. Oh my God, when I was getting sober, if you could have just offered me something I didn't have to go to therapy and do a lot of work, hell yeah. But like, it's not going to be a quick fix. And I think that's my concern is that clinicians just start throwing it around as a quick fix. Um,
I feel
those are,
like I've seen improvement in that as far as getting more referrals, or even my PCP, a while ago had this like, I'm destroying their metabolism. I was like, yeah, how many of you sent to a dietitian? Like none of them. Like, let's talk about that. So I think some of them have come to the realization that like the muscle mass and stuff is actually causing negative effects, and I do see more referrals and more conversations about that on the medical side of it than I used to. Um, but that's highly anecdotal and dependent on the doctor and how much they're. Mm.
yeah. Does
I don't know if
anyone
y'all
else?
saw Jackie posted a podcast in there. I think if y'all keep dropping links in there for sure, what I'll do is download the chat, and when I put this on YouTube, I'll put it on the discussion board with the chat log as well, so y'all can pick up these links if you're not able to nab them right now.
Um, Awesome. Any thoughts, questions? I mean, we have such a big group. I'm sure other people are have some experience with this.
No.
Does anyone maybe raise your hand if you have any patients, clients on a GLP-1 in general? Okay, I see one. I see a few hands. And are you all, I guess, broadening context to kind of Stephanie's point of just how they're integrating nutrition care for clients that are on the medication? Are you guys seeing that clients are resistant to working on their nutrition while on the medication? Is it motivating? I have some clients that are like, well, since I know I have to maintain muscle mass, maybe suddenly I'll now want to go to the gym once I'm on the medication. And it's like, okay, maybe. Any experience from the field that anyone wants to share?
So I've seen in my setting a few patients do have increased motivation after starting GLP-1s because they're seeing what they deem as really desirable health outcomes.
Mhm.
And so that kind of builds this innate motivation and they keep going with it. But like you said, it's a short-term thing. And I've also seen these GLP-1s increase risk of depression and just an overall loss of interest in a population that's already so vulnerable to that. So, definitely concerns there.
Yeah, some of that's probably just not eating enough, right?
Hmm.
Um,
And then kind of going along with that, I've been so surprised. They'll come in to me and will have been on GLP-1 for months, and I will sit down and just for a second. So, have you ever received nutrition education for GLP-1? Has anyone talked to you about protein? And no, like they are just simply given this medication with no type of
Peace
nutritional
out.
counseling to go along with it, and that has just really shocked me.
Yeah. Yep.
To
I've
go along
definitely
with
seen that. Oh,
sorry,
go
with
ahead,
Sarah,
Jackie.
that is one of the things that's frustrating is that I've seen enough clients that they've had no instruction. And then I would ask, like, so when are you following up with your doctor? It's been 4 weeks, blah, blah, blah. Never.
Mm.
How? Like, how can you not? And that's where I've kind of like, I used to hate GLP-1s a few years ago. Now I've had that mindset where it's like, why fight against something that's just not going to go away? So trying to get out there more and letting doctors know that you should not just throw them on a medication and
there's that.
okay.
I'd say most of my clients that have any kind of nutrition education got it from support groups on Facebook.
Oh yeah.
Yeah.
Yeah. I'm with you, Jackie. I think in the beginning I was like, oh, GLP-1s, here we go, another thing. And now they're not going anywhere. And I feel like with every day, it's like, great. Now we just, there's no, what's the word? Like we're always taught like be weary of things with big promises. And I feel like with GLP-1s, it's just a new day, new research on like this is the most incredible medication ever. And yet we're seeing like malnutrition. And so it's not going anywhere. But I think what came to me too, to Stephanie's point that I didn't touch on, is like this idea of screening for eating disorders. And who's disclosing what when they talk to their doctor. Most people just want to be on the medication. They're not going to disclose that they purge every now and then, or, they're already restricting their food. So yeah, there's a lot of work to be done on training doctors and other clinicians.
I've
I
kind of seen,
definitely agree. I feel like the cart definitely came before the horse with the GLP-1s. I work mostly acute care, like in a medical, like hospital setting. And on our end, we have been seeing more cases of people being admitted for like constipation, dehydration, but oh, they just started a GLP-1. So both the providers who admitted them plus the patient themselves, wasn't aware that this was a possible side effect of starting this medication.
Yeah, I've had an ileus end up in the hospital. Yeah.
Yeah.
Something else that I've seen come up that it's only been a few, they've lost so much weight that then it starts this whole new thing where they want to get surgery to remove the skin. I mean, rightfully so. It's not my place to say that they shouldn't do that, but that's huge, huge surgery. So I don't think that even something like that, they're not thinking about that long-term effect. And that's another thing that I struggle with because they're eating such a small amount of food. Naturally, the medication, the amount of nutrition that they're getting is not what they should be at for a big surgery like that. So that it's like it's nerve-wracking.
Totally. I mean, the post-op possibility of infection and slow rate of healing if they're not eating enough. Yeah, absolutely, Jackie. Scary. I see Erica, your hand's up.
Yeah, I have a patient that is in a recovery inpatient that I work in, and he was struggling because he's recovering from alcohol abuse, and he is had bariatric surgery, and he's on a GLP-1, and I'm like, what? Like it is just such a bad combination because he's not eating hardly anything, and we need him to get enough food, right? But his stomach is so tiny, and so we're like constantly, and he requested a consult with me because he wanted to start building muscle, and but he wants to lose weight. And I was like, well, those two don't go like calorie wise, and but just getting enough food into him is my priority right now. And I don't know why they would put him on a GLP-1. So I have a meeting with the MD actually tomorrow to discuss his situation because, I don't really think that he's a very good candidate for GLP-1, but, had he not had this surgery, then okay, right? But there's just so much going on with him as well, like he's lost 400 pounds, and, and now he's like also mentally like going through a situation where he's like terrified of gaining any more fat. So he doesn't want to eat more, but he wants to gain muscle, but he wants to lose weight. So he's like, oh my God, like it is quite a complex case I'm working on with this guy. So, I've got the whole team we're having a meeting tomorrow to figure out our next steps with him because like we don't want him to get discouraged, and but we also want to set realistic goals for him. And so it's, I don't know, I feel like the GLP-1 might be kind of just causing more of a problem in his case than it's actually helping. I don't know.
Oh my God, how old is this person?
He is, I believe he's 32.
Wow. And he lost
Yeah.
pounds over.
Yeah. Yeah, so he was like 600 and I want to say like 640, but he had some kind of spinal injury as a child, so he was just constantly like laying down, and then he had a lot of people around him kind of like bringing him food like he was a marathon runner, and he said by the time he was like in his 20s he was like almost over 400 or 500 pounds, you know. So, and then he just got depressed, started drinking a lot, and that didn't help. And so, but yeah, had this surgery, lost a ton of weight. Then within the last year, they put him on GLP-1s, and all he was eating was alcohol, and finally got clean or got sober. And so now it's like this, like we got like tug of war going on like which direction we're going first with him. It's a complicated, case, and so we're hopefully tomorrow we can find some kind of a direction to go with the team.
Has he said anything about alcohol cravings on it?
He did say actually the last time that we met, which was Friday, he mentioned that he has no desire to drink anymore. So maybe it's helping with that, but because he's been sober now for about 6 weeks.
Wow. Interesting.
I'd
Yeah.
really be curious if you find out, Erica, about like any specific like rationale or reason as to why the GLP got added on last year, after he had
Yeah,
that whole surgery to start
yeah,
with. It does seem a little bit redundant, or I don't want to say overkill because I don't know the
yeah.
patient, but I've never come across that before.
Yeah, I completely agree. So yeah, that's tomorrow when we get together with the MD and everybody. That was going to be my very first question is like, why is he on a GLP-1? Somebody please tell me. So, we have a really great team, which I'm very thankful for, where like the MD really is, I know I know people say this all the time, but I just don't ever feel like a lot of the MDs really take what I'm saying all that seriously sometimes. But this place, I'm so grateful that we have such a great team where everybody's very respectful of everybody's scope of practice.
That's awesome.
That's awesome. And if you can, please keep us updated on the discussion board.
Yeah, absolutely. Absolutely, I will. Thank you.
Yeah, I think something else I just wonder, um, in this population of like, it's amazing that cravings could possibly be eliminated or decreased, but I just wonder in terms of the skills that one should be learning in recovery. Like, I think I worry that, oh, my cravings are gone. I don't need to build skills around distress tolerance or how to cope or building community. I worry about the long-term recovery for these people if it's just going to be like GLP-1 as a way to help somebody be sober. Any other thoughts or questions on this topic before we shift to group topics? I mean, we have such a robust group of dietitians on here. I'm sure we can get some great ideas.
I'm just curious. Not that it has to be a big conversation or anything, is how anybody's seeing use of phentermine lately. So I've seen an increase outside of GLP-1s for weight loss and phentermine, like by quite a bit. Like I've probably got 7 or 8 of them on it right now. And I have started to see them combined with GLP-1s now. So I've got somebody right now on Zepbound and phentermine. I'm just curious if anybody else has seen a resurgence in use of phentermine. So it's been directly coincided with when GLP-1 started getting more popular. I started seeing more fentanyl too. You've seen bariatric patients on GLP-1s. Yeah. I was just curious. I've noticed it pretty markedly. It's like, it can't be the only one. But I, nobody's given me the rationale, or maybe their doctor didn't tell them like why, if they went in for a GLP-1, they left on phentermine, or, um, those patients are getting monitored. They're going in for blood pressure checks and lab work and stuff like that, at least. But I was
I
just
didn't even
curious.
know people were still prescribing that these days.
Mhm. I feel like before I was seeing a lot of Topamax
Yeah.
being used for weight loss. But yeah, I would argue, and it's not necessarily something I track, so I can't like prove it in my practice or anything like that. But around the same time the GLP-1 started getting really popular, I started seeing an increase in, not an increase, I started seeing phentermine, and then it seems like it's been getting increasing like since then. So
Well, one thing I am seeing with one particular private practice in New York City of endocrinologists that are kind of like just doing the GLP-1 thing is they'll add on naltrexone for clients that are not seeing the results that they want.
fail the other. That's true. I don't know if
Which
that's going on too.
which is just interesting, if we think about like polypharmacy and how people, don't want to be on a lot of medications, but when it comes to weight loss, I mean, anything goes.
Yeah. I don't know that I see naltrexone necessarily by itself, but I have seen Wellbutrin a lot for that same, I think, idea. And then sometimes Contrave. That's the two combined.
Yeah, that's what I was just going to say. The Contrave, the two
Mhm.
naltrexone and bupropion.
Yeah. Sorry, I was
Um,
just curious about that. If I think the group conversation will be super interesting too. It's actually something that at one point I started creating a resource for that, and then I think I just got sidetracked. That I thought it would be a good, like some people would have a lot of questions about it, and this last week or so on the discussion board, it's definitely something I think people are interested in. So, um, was it Jackie? No, it wasn't Jackie. Who was it that started that? Lisa. I think sometimes the groups that you go over are going to depend on your setting. So I don't, if y'all have any ideas to go into that, but Lisa, if you want to show like age type of setting, if you're seeing a length of stay of 10 days, that's a lot different than somebody with the length of stay of like a, residential rehab for like 90 days and age groups and things like that. So
12 to 18 years old, 120 days. So one thing, Lisa, that popped into my mind just to piggyback off of this conversation is, I mean, you'd have to definitely tailor it to teens if you're comfortable talking about it. But I think talking about body image or introducing that topic, it's kind of a big one, but is a really important topic, especially as some people have hit on of like, there are weight changes when someone enters treatment. Um, there I've seen it when I worked in an addiction facility. We'd have clients that now they were sober and their new obsession was getting ripped. And just the addiction transfer that can happen, but it's kind of a bigger subject in and of itself. But even just a little bit of like awareness or an introduction into body neutrality could be an interesting like multi-series, multi-part group.
yeah, I would almost argue if you haven't taken training on body image that you should probably do that before you start doing groups on that. um, so, I mean, there's lots of resources for that. I'm sure, Sydney, you have some really good ones. I did with Amanda Mittman, who worked with Bree Campos on body image training. Um, my kind of gold standard that I want to take is the not you see my blame break. Did y'all see that? I got an email from them today.
Marcy Evans?
Her too. Um, it's gonna bother me. Hold on, I'll look it up. But there's a lot. There's a lot of different ones.
I'll also drop in the chat, there's a wonderful therapist that specializes in eating disorder prevention in adolescents, and she might have some great resources. Yeah, any other ideas on groups that people run? I mean, it's such a big group.
Yeah, I was gonna chime in a little bit. I'm a dietitian at a substance use treatment center in Florida, and one of our programs isn't teens, but a lot of like adolescent, I would say like 20 and 30-year-olds. And a group that I've done with them is a body neutrality group, and I'll have them pair up and they'll basically write out 5 body neutral statements. And then their partner will also write it out, and then they will share each other's statements to the group, which I think is really powerful. So they would say, Sally appreciates, the way that her legs are able to get her to and from treatment today, or something like that. So saying it in kind of like the third person. So just doing an activity like that I've seen to be really helpful. And then also I've done a mindful eating activity with them. So I've brought in um, the particular snacks I use are clementine and some kind of like candy. And I'll just like put them at the front of the room and we'll talk about mindful eating, like what that means. I'll even go into intuitive eating if I have like a pretty long group. And then we walk through a mindful eating experience. So, like, I'll read through like a mindful eating experience with them. I will tell them to go choose whichever food feels like appropriate for them at that time, whether it's the orange or the candy. And then, yeah, we kind of like walk through a mindful eating activity together. And I've gotten like a lot of really positive feedback from that particular group of people.
Awesome. Yeah, I think mindful eating is a wonderful thing to bring up. Yeah, Lori.
Or-
Hi. Um, can you hear me? I'm sorry.
Yes.
I'm retired now, but newly retired, but I worked with veterans for the substance abuse. And I was, how can I put it? We worked a lot with, trying to get nutrition into the substance abuse, like whole health, things like that. I finally ended up contacting the head of the thing and getting hold of their residents and using the residents to introduce all the thing about the nutrition and for the weight loss or for the substance abuse or something like that. And that got accepted much more readily than trying to go after the top guy, which is kind of, they were much more open to it. I had learned, about the GLP-1s, cutting back on the cravings. However, I also know that sometimes that starts waning the longer you are on the medication. So, sorry. So I was wondering if anybody else had seen that also. If the longer you're on it, the less effective it is for cravings.
I don't work directly in rehab anymore, so I don't have any insight into that, but I'm wondering if I think I'm trying to remember who the names that are on here who told me they worked in facilities and stuff, but um yeah, I mean I feel like that makes sense, right? That's common in a lot of different medications, right? Especially psychiatric impact.
I haven't seen it here. But like I said, our patients are only here for, usually 28 at most, maybe like up to 6 weeks, 6 or 7 weeks with PHP level of care. So we really don't have the window to kind of see that, I feel like.
One of the things I'll say that really helped me with like body image and to some degree mindfulness in the group setting was having a rotation where I could come back to the topic while there were still people that had seen it the first time, if that made sense. Because they were better at like in that short time period, so to speak, of like how they've utilized that talk. So, like to bring it back around, different exercises and stuff that I would do with them that, they thought were stupid the first time I introduced it, but now that they've seen it towards the end of their recovery, how they can see how it impacted and stuff like that. So I wouldn't be scared necessarily of repeating topics within the group, especially because, they're not if they're well nourished, right? Even without an eating disorder associated with it, sometimes malnutrition comes before substance use, even. So, giving their brain time to kind of get renourished and caught up. Bless you, Sydney. So I think that would be a big one. I think we get really caught up. I know I did when I first started doing groups of like I was never supposed to show the person like they already saw it. They don't need to be bored and listen to me chatter again. But the group setting is different, right? The people are different insights and stuff like that. It can be helpful to intentionally repeat certain discussions in groups.
Thanks, Jackie. This is my dog, Charlie, just staring at me like a creep.
I
Yeah,
love that. That's great.
staring like a creep. Because you're working with adolescents, I just had a thought too, like yes, prevention and the body image piece, but I wonder, um, I don't work with a ton of adolescents, but like the 19, 20, 21 year olds that I work with, I'll talk to them a lot about social media and like show them how they can create filters on their social media. And so they're like not seeing, I mean, we don't have so much control, but like kind of editing their algorithm so they're not seeing, I don't know, I don't even know what substance use content is out there today, but for substances or body image or like eating disorders, Yeah, I just really think about prevention with this group, or even just when they get home, like little nutrition education things like why snacks are important for mood and like that it shouldn't just be Takis, but maybe we're having like Takis with a string cheese, right? Like simple nutrition things like that. I used to, when I would do a group, like it would just be breakfast. Why is it the most important meal of the day? Or like how to build a snack. My favorite, it's kind of harder because it's adults, but I would have a group um, like myth busting. And so everyone would just bring one thing that they think they know about nutrition or food. And we'd talk about it. And those were always fun because I'd be like, oh my God, I didn't even know that was a thing. Um, it's amazing what clients can teach you about what's out there nutritionally, and it's scary.
Oh, they all want to teach me about seed oils right now. Already had that conversation twice today. So, yeah. I think asking them too, what do you want to talk about is a big one, yeah. And then depending, so adolescents, they should have had some type of health class already, right? So they're familiar with like the My Plate and stuff like that, but that can always be something brought. Food models, I found kids really liked food models if you have access to those. Adults don't tend to like them, but the kids do because they're kind of gross. I don't know. um, yeah, I think you could tack on movement to body image and mindfulness, right? I'm trying to think of like really like nutrition, food specific, anything experiential, right? Uh, Probably not grocery store tours with that age, but like they said, mindful eating, maybe decorating cookies during the holidays and things like that.
Another one, like caffeine can be a huge group, especially for that age and especially for substance use, just like giving some knowledge about caffeine, not like we have to abstain, but just maybe why 4 Celsius and a pack of Zyn is not great in a day.
Especially if you can relate that, talk to them about how it relates to anxiety and, yeah.
I know we talked about it on the in the member chat. This would be a great group for like the cooking because anytime when I worked in the facility where it was ages 18 and up, that one I did get a lot of them were like 18 and 19 years old and had zero experience in the kitchen, which hurts my heart because I always made sure that my kids were involved in the kitchen. So, um, a lot of survival.
So great. I know from where I used to work, there was like insurance things about the kitchen, but what they would allow me to do is like bring a blender into groups or do like energy balls or like any like making a bowl where the food's prepared and they just have to like assemble it or could be great if you're not allowed to bring them into the kitchen.
For anybody doing adults, I think maybe menu or like meal planning or things like that, making that easy. Or another one right now would be a good one is using some of those processed quote unquote foods to make life easier. That it's okay to buy chopped up things or things like that are getting that you're not cheating if it's easy, that kind of thing.
Next week, I'm doing cookie decorating.
Yeah.
I love it.
I'm blessed with being able to just do whatever.
Oh, that's amazing. That's incredible.
I had a question for the group going back to the caffeine real quick. So, I mean, I'm kind of new to the like like kind of this area of nutrition. Like I said, mostly I'm in like acute care. But for the populations that y'all work with, like, have you noticed that, say, during recovery, there is like either a switch or, some type of like increased use of caffeine What? Oh, I'm seeing heads nodding. Do tell, do tell.
Caffeine and sugar cravings are really, really common in recovery. Yeah.
Gotcha.
I'll share personal experience. Like, I never really drank coffee in college. It made me feel horrible. And then I got sober and oh my God, was doing like 6 cups of coffee a day, just like anything, right? To shift how you're feeling in your body, get some sort of rush. I'll just share too, like personally, but also in my like world of fellow recovery people, this funny thing can happen sometimes where you feel anxious and anxiety or caffeine can make you more anxious, but then it's just like you keep throwing fuel on the fire. But yes, it's very, very common. Um, yes, Erica, totally. That's why I'm still meetings. Even a 9 p.m.
Oh my
meeting,
gosh, wow.
coffee. Yeah.
Wow. Yeah, I can definitely see how that will definitely start to kind of spiral anxiety and other mood concerns.
I think there's some statistic that caffeine is like the greatest addiction worldwide.
Trying to remember that while you were talking. It's like the most abused neuro, I can remember the word, is why I didn't say it. Neuro something, neurotropic drug or something.
Yeah. Um, yeah, and I think it depends on like facility too. Some facilities will have clients like no nicotine policy, no smoking policy. Other facilities allow it. Some facilities like will have a caffeine cutoff. Our facility did. Some don't. And I think it just kind of goes back to like that addiction transfer in a way. Yes, Erica, preach.
Yeah, I'd also tell you, encourage you not to, like she said, encourage complete cessation, like bring it back, maybe cut it off or reduce, like you mentioned the Celsius, those are like 200 milligrams of caffeine, right? So like maybe coffee would be a better choice if that's what we're doing 3 or 4 of a day, right? But I generally have found most people are going to start drinking again because of the withdrawal symptoms far before they ever notice the benefit of, less anxiety.
That's really good to know because our addiction recovery center has recently reached out and they're asking for us to do like more
Hi,
programming with
Jackie.
them because they're noticing issues with like eating 12 cups of ice cream from the freezer, like a lot of these sugar cravings. So caffeine would be a really good topic then it sounds like. So that's great.
Caffeine would be, and maybe normalizing sugar increase during that time if you can. It's hard and it's distressing for people, but it is super common, especially with alcohol and opioids.
Mhm. Colleen, quickly, did you have a question before we wrap?
Yeah, I was just going back to I think you mentioned something about smoking, Jennifer. I was wondering if anyone had addressed, maybe in group, I don't know if this is out of our wheelhouse, or any issues that you've had in group or with clients about vaping. So most of the centers I'm at, they dispense vapes and they're not allowed to vape in groups, but they do. So I end up having to address it. So I was just wondering if there was anybody else that has experienced that or how you've addressed it or anything like that.
That people vape? You mean the issue of like vaping during your group or just like vaping in general and how that
Just in general, they brought it up to the director or anything that the way that it's just so prevalent. Because I've had a lot of clients that report to me now that they never vaped before and they picked it up since they've been in treatment. So they're reporting it to me. So I'm just curious if this is like a thing that's all across the board or what anyone else's experience has been.
you
Um,
say the treatment center dispenses vapes, like gives vapes?
they have a dispenser that they it's locked up, but yeah. Yeah, so it's almost like they do give them smoke breaks, but they have they have smoke breaks, but then you come back in, and I've noticed a lot of my clients that I particularly don't allow vaping in groups. So a lot of them will excuse themselves to go outside and vape. So I'm just curious.
That is not something I dealt with
Yeah.
in my groups.
We see it here all the time at
Okay.
Yeah,
Karen.
I see it here all the time as well.
Yeah,
Okay.
yeah.
I'm like,
Yeah.
okay, what is this? And because I talk a lot about, I mean, I touch up on alcohol metabolism a lot in group, and some of the same chemical, like one of the same chemicals in alcohol metabolism is also found in vape. So I'm not sure how to address it to them from a physiological standpoint, if I should bring it up, or if this is just something that you guys, keep just keep informing them that we don't allow vape in group and just leave it at that. So,
I think something that I bring up often is that caffeine and nicotine are appetite suppressants.
okay.
I think that's something that I talk about in lecture often of just, different things that are affecting their nutrition status and appetite, and that vaping consistently throughout the day is, I'll have clients a lot of the time like, I don't know, I'm just not hungry and I'm only eating one meal a day and I don't really think that's a problem. And I'm like, okay, well, do you think it's the 7 coffees and 20 cigarettes you're having throughout, just like pointing out these things that are possibly also affecting their appetite. So that's just kind of the direction I usually go with it.
Okay. Yeah.
More in general, like when I give like a big auditorium lecture with many of the patients, and I talk kind of like what Sydney was saying. I mean, anything to like get a rush or like release the dopamine and serotonin that they're not getting from substances, like they're going to gravitate towards, which caffeine and nicotine also do. So I think one of the biggest things is like learning coping mechanisms and distress tolerance and CBT and like things they're learning in treatment, to try to manage that as best as possible. And again, not the abstinence piece. Like it's okay to like do those things and a little bit to give them a little bit of something because they're not getting anything can be helpful early on, and also learning the tools that they need moving forward. I know like here, like we educate on like, nicotine use often goes hand in hand with substance abuse because it engages that same reward pathway in the brain. So a lot of times they're like tied together as well. So it really depends on the individual and like what's best for them. But I talk about that in general and how, it's easy to turn to something to use to get what they're not getting anymore from substances. If that makes sense.
I wonder at like a facility like policy level, that almost sounds like ours had like set times. Like they kept everything locked up and that like at smoke break. And it was like I think there was 4 or 5 a day, something like that, but they were at this time. They couldn't just like go ask the nurses for it and then go whenever. Which is almost what it sounds like you're describing if they're just leaving group to
Oh,
go.
yeah. They
Yeah.
have it in their hands when they come in, all of them. So,
Yeah. It sounds like that needs to be like a facility policy
yeah,
as far
I
as
mean,
like,
it is. There's a policy, and I have to go through the rules before groups because, these people are in there for a short amount of time, and then you get a new group. So it's like you're constantly informing them that there's no vaping. But I just feel like it's and I like again, I'm across several facilities that it's so prevalent that I didn't know if it was just
yeah, I think I meant more like the facility needs to review their policy on like allowing them to have it outside of those times. If it's getting that disrupted, your group's not the only one getting disrupted by that then, you know.
Oh yeah, well we've had a couple of other facilitators, not dietitians, that have complained about it. So
Yeah, that sounds like a like 10 o'clock smoke break. Come now, you don't get it, like it sounds like that needs to be a little bit more
The
um
Yeah, sorry to cut you. The last thing I'll just add on the vaping for like groups or whatever is sometimes clients are shocked that vaping can or nicotine can contribute to like reflux or heartburn. And so especially when, they're newly sober and your gut's healing, it doesn't really move the needle, but I'll educate on that a little bit and how something I do with clients is like if you're vape is like most people don't even know how many milligrams of nicotine they're consuming, but if it's 5 milligrams or 9 milligrams, like setting a goal to like decrease, over a few weeks' time, can be helpful and motivating. So they feel a little bit better.
think I am hearing that I need to jump off. I've got to go get my kid anyway. So I don't know if I end this, if y'all will be able to stay on it. So I just wanted to run that by everybody. But I will once this gets processed and I get back and everything like that, I'll get that onto YouTube as soon as possible. And like I said, I'll upload the chat as well, so y'all can grab those links. I think Sydney, you added some on body image. I added the ones I was thinking. Body trust is the one I was thinking of, by the way. And then yeah, we'll have all of that. And y'all, if y'all want to continue any of these conversations in the chat, I feel like a lot of people get a lot of value out of that. So definitely bring that forward there too.
Thanks everyone for joining.
Awesome. Thank you, guys. All right. Bye.